Welcome back to the deep dive. Today we're tackling a big one. It's that piece of lab work that, makes a lot of people sweat.
The ABG, absolutely. The arterial blood gas.
It feels like just a wall of numbers when you first see it, especially
Yeah.
when you're in a high pressure situation.
It does. But it's an incredible puzzle. It's a perfect snapshot of what's happening with a patient's breathing, their metabolism, their entire acid-base chemistry all at once.
So our mission for this deep dive is to give you a shortcut, a really clear, systematic, four-step way to look at it. This isn't about memorizing, it's about seeing the story.
Exactly. You have to follow the system. It forces you to connect the dots and see how everything interacts. You're looking for the cause. Is it the lungs? Is it the kidneys? And then how is the other system fighting back to fix it?
Okay, so let's unpack this. We'll start with the building blocks, sort of our map for the journey, and then we'll get right into those four steps.
Sounds good.
So to start, we need those core parameters,
Yeah.
the normal ranges that we're always comparing back to. And the absolute center of it all is pH.
The pH is everything. It sets the entire tone. The body is obsessed with keeping a very, very tight range for pH.
And that range is,
7.35 to 7.45.
so not a lot of wiggle room there.
None. If you're below 7.35, that's acidemia. If you're above 7.45, that's alkalemia. And either way, it means there's a serious problem, a crisis.
Okay, so once we know if we're acid or base, we have to find out why. That brings us to the two main players, right? First, the respiratory system.
Right, and we measure that with the PACO, the partial pressure of carbon dioxide. The normal for that is 35 to 45.
And the key thing to remember here is the relationship to pH, which is a little counterintuitive at first.
It's an inverse relationship. Chios is basically an acid. So if your PACOs goes up above 45, you're holding on to acid. Your pH goes down.
That's respiratory acidosis.
Exactly.
Mhm.
And if your PACOs goes down below 35, you're blowing off too much acid and your pH goes up. Respiratory alkalosis,
Then you've got the other side of the coin, the metabolic component.
which is all about bicarbonate, or HCROs. This is what the kidneys manage, and the normal range is 22 to 26.
And this one is more straightforward, relationship-wise.
Much more. It's a direct relationship. Bicarb is a base, so if your bicarb is low, below 22, you've lost base, and you get a metabolic acidosis.
Makes sense.
And if your bicarb is high, above 26, you have too much base. Metabolic alkalosis, those three pH, PACO, and HCO, are the absolute core triad.
Okay, just before we jump into the four steps, there are a few other numbers on there, like base excess.
Yeah, base excess, or BE, is a great little shortcut. Normal is plus or minus 2. If you see a big negative number like -8, that's screaming metabolic acidosis.
So it confirms what the bicarb is telling you.
It's an immediate confirmation. Yep, it's a really handy tool.
All right, let's get into the process, the four-step sequence that makes this whole thing manageable.
Okay, step 1 is the easiest. Step 1, check the pH. That's it.
Just look at the pH and decide. Are we acidic, so less than 7.35, or are we alkaline, more than 7.45?
That's your starting point. It's the compass for the whole interpretation. You can't go anywhere until you've answered that one question.
Okay, pH is set. Now, step 2, identify the primary disorder. We're looking for the culprit.
Right. You look at the PACO and the HCO and you ask which one is causing the pH problem. The one that's moving in a direction that explains the pH change is your primary disorder.
Let's run through the four patterns to make that really concrete. Let's start with the acidosis.
Okay. First up, respiratory acidosis. Your pH is low and your PACO is high.
So the lungs aren't blowing off enough COOs, they're hypoventilating.
Exactly. Think of a patient with a severe COPD exacerbation, or someone who's taken too many opioids and their breathing is shallow. They're retaining all that acid.
Got it. Then the other acid state, metabolic acidosis.
Here, your pH is low and your bicarb, the HCOO, is also low.
This one feels very serious.
It often is. It means you've either lost a ton of base-like from severe diarrhea, or more often you've gained some other kind of acid that's not CO.
Like in DKA, diabetic ketoacidosis.
DKA is the classic example. Or kidney failure or lactic acidosis from sepsis. Major red flag.
Okay, moving over to the alkaline side of things. High pH.
So, respiratory alkalosis. Here the pH is high and the PACO is low.
So they're blowing off way too much acid.
They're hyperventilating, breathing too fast. This is your classic panic attack, or maybe someone in a lot of pain or with a high fever.
They might feel tingly, lightheaded.
That's right. And finally, metabolic alkalosis. The pH is high, and the bicarb is also high.
So way too much base in the system. How does that happen?
Usually it's from losing a massive amount of acid. The most common cause is severe prolonged vomiting, where you're losing stomach acid, or sometimes from heavy use of diuretics.
So identifying one of those 4 patterns is the absolute foundation, but it's rarely that simple, is it? That the body doesn't just sit there and take it.
Not at all. And that brings us to what is, I think, the most interesting part. Step 3.
Step 3, assessing for compensation. This is where the body starts to fight back.
It's the counterattack. If the primary problem is in the lungs, the kidneys will try to fix it. If the primary problem is metabolic, the lungs will jump in.
So you're looking for the opposite system to change in a way that tries to push the pH back towards normal.
Precisely. And the timing here is absolutely critical. This is a key point.
How so?
Respiratory compensation for a metabolic problem is fast. The lungs can change how much QO you're blowing off in minutes.
But the other way around
is slow. If you have a respiratory problem, the kidneys take hours, even days, to really ramp up or dump bicarbonate. That tells you a lot about whether the problem is acute or chronic.
So when we see compensation happening, we need to classify it.
Right. Is it partial or is it full? Partial compensation means the other system is trying, but the pH is still abnormal. It hasn't gotten back into that 7.35 to 7.45 range yet.
And full compensation?
Full compensation is when the body's efforts have been successful. The pH is back in the normal range. But, and this is key, the PACO and the bicarb will still be abnormal. They're the fingerprint of the fight that's going on underneath.
Okay, so this is where we really get into the deep dive. For metabolic acidosis, you can't just see that the lungs are compensating. You have to ask if they're compensating enough.
Exactly. This is where you have to look for a hidden or mixed disorder, and for that, we need a special tool.
Winter's formula.
Winter's formula. It's a beautiful little calculation that predicts what the PACO should be for a given level of metabolic acidosis.
And that formula is expected PACOs equals 1.5 times the bicarb plus 8 plus or minus 2.
That's the one. That 1.5 ratio is based on pure physiology. It's incredibly reliable. You calculate the expected PACO range, and then you look at your patient's actual PACO from the ABG.
If it's not in that predicted range.
Then you have a second problem. For instance, say your patient has DKA, their bicarb is low, and Winter's formula says their PACO should be, say, 25, but their actual PACO is 40.
They're not breathing as fast as they should be.
Right. They also have a primary respiratory acidosis on top of their metabolic acidosis. Maybe they're getting too tired to keep up. It's a huge warning sign.
And there's another crucial calculation for metabolic acidosis that gives you so much information, the anion gap.
Yes, the anion gap, or AG, is essential. It helps you figure out the cause of the metabolic acidosis.
I always found this one a bit confusing, but the calculation itself is pretty simple. It's your sodium minus your chloride plus your bicarbonate.
Exactly. And a normal gap is about 8 to 12. What you're really doing is looking for unmeasured anions. The gap is stuff like ketones or lactate or other toxins that aren't on your standard chemistry panel.
So if that gap is high, say it's 22, that's a major clue.
It's a huge clue. It tells you the acidosis is caused by the gain of a new acid. And that lets you use the Muddy Piles mnemonic to narrow down the cause.
Mud piles standing for methanol, uremia, DKA. All those really nasty causes.
Right. It points you directly toward things like DKA, renal failure, lactic acidosis from sepsis, or even certain poisonings.
And what if the anion gap is normal?
A normal gap with a metabolic acidosis tells you the problem is likely from the loss of bicarbonate, not the gain of a new acid. The classic cause is severe diarrhea.
And that completely changes how you treat it.
Completely. High gap, you treat the underlying cause, the DKA, the sepsis. Normal gap, you might need to actually give the patient bicarbonate to replace what they've lost.
So we've looked at the pH, we've found the driver, we've assessed the compensation. There's one last piece to this puzzle.
The final step, step 4, evaluate oxygenation status.
We're circling back now to the PAR, the partial pressure of oxygen.
Right, and again, the normal range is 80 to 100 millimol Hg. Anything below 80 is hypoxemia.
And there's a critical number to watch out for, isn't there?
There is. A PAO below 60 millimol Hg is considered severe hypoxemia. That's when the amount of oxygen attached to your hemoglobin really starts to plummet. It's an emergency.
And the reason this is step 4 is because it connects everything back together. Poor oxygenation can cause some of the acid-base problems we just talked about.
It's the final link. If your tissues aren't getting enough oxygen, they switch to anaerobic metabolism. And what's the byproduct of that?
Lactic acid.
Lactic acid, which is an unmeasured anion that causes a high anion gap metabolic acidosis. See? It's all connected. You can't fix the pH without also fixing the oxygen problem.
So that's the system. pH, primary driver, compensation, and finally oxygenation. Following those steps in order really does turn that wall of numbers into a clear story.
It does. It gives you a clinical narrative, and it prevents you from missing those subtle mixed disorders that can be so dangerous. It's the difference between just reading a lab value and actually understanding the patient's physiology.
We've covered the whole map of ABG interpretation. It's a powerful tool when you approach it systematically.
It is, and that leads me to a final provocative thought for you to consider, building on this idea of compensation.
Okay.
Imagine you get an ABG, and the pH is 7.37. Looks fine, right? Totally normal.
Right in the normal range, no alarm bells.
But then you look closer, the PECO is 60, which is very high, and the HCO is 34, also very high. That's not a normal person.
That's full compensation.
That is the body working incredibly hard just to drag that pH back into the normal range. That fingerprint of the high euro and high bicarb tells you there's a severe chronic disorder still going on underneath. So how do you distinguish that massive effort from true normalcy? What does that silent battle tell you about the body's sheer constant effort to maintain that fragile equilibrium? Something to mull over until our next deep dive.